Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Overcome, and today I'm joined by a very special friend of Overcome, Cathy Sullivan. So Cathy is a certified genetic counselor and instructor at Baylor College of Medicine, and her professional interests include hereditary cancer risk assessment. As I just mentioned, she's a great friend of Overcome. She's passionate about patient care and, of course, all our Overcomers worldwide. So join us for the next 45 minutes to an hour as we chat with Cathy about all things genetic testing and counseling when it comes to ovarian cancer. And if you have any questions as we go along, please type in the comment sections below and we will get it addressed post the discussion. So with that, a huge welcome to you, Cathy, to this episode of Connect Over Coffee. Always such a pleasure to see you and have you with us.
Oh, thank you, Renzi. I'm happy to be here.
Thank you, Cathy. I have a lot of questions, so we'll just delve right in. So
Let's go.
yeah, exactly. So before we get into the details, just tell me briefly, why do you think genetic testing is important?
Yeah, in the most simple terms, it could really impact the treatment for a woman with ovarian cancer. So that is absolutely the most number one reason it's important. But it can also alert us as to whether or not a person and their family members are at an increased risk for various other types of cancers. And so it could really allow people to be more proactive in regards to their cancer screening and their cancer prevention.
Wonderful. And so, just building up on what you just said, so what are the genetic factors that may drive the development of ovarian cancer, you think?
So I think we need to be careful about the way we think about this because there are really two different types of mutations that are discussed when we think about genetics driving cancers. So really, all cancers are driven by genetic mutations that arise within the cancerous cells themselves. And we call this type of mutation a somatic mutation. And these are mutations that we acquire during our lifetime. And really, all ovarian cancers are driven by mutations like this that arise only in the cancer cells themselves. And basically, the cells acquire these mutations and it causes the cell to go haywire and change from a normal working cell into a cancerous cell. And so when doctors talk about mutations driving cancer cells, they're often talking about these kinds of mutations that arise specifically only in those cancer cells. And I think it's also important to say that these types of cells or these types of mutations are not in every cell of our body, which means they're not in our eggs or a man's sperm. And so these kinds of acquired somatic mutations are not the type of mutations that can be passed from generation to generation in the family. So typically when a genetic counselor is talking about genetic testing or talking about mutations, we're talking about a different kind of mutation. So what we generally talk to people about are the types of mutations that we're born with. And these would be mutations that would be in every cell of our body, including our germ cells. So again, our germ cells, those are our eggs or a male sperm. And so these are the kinds of mutations that we see passing through generations of a family because they can be passed to our children. And these are the types of mutations that can give us a higher predisposition to develop cancer. And only about 15 to 20% of ovarian cancers are caused by these kinds of underlying hereditary germline mutations. So, actually, I feel like I'm getting ahead of myself. I think it would be helpful if we could have a quick crash course in genetics, if that's okay. I hate to be throwing out words like mutation without even defining what I mean by that. And I think it just might be helpful if I could give sort of just a quick overview of some basic concepts to make sure we're all on the same page moving forward with some of these terms.
Absolutely. Okay? Yeah, absolutely. Okay. That'd be wonderful. Yeah.
Okay. Because I hear myself talking about mutations in genes, and I know that some people may not know what I mean by that. And so some of you may know that when you were born, you inherited thousands of genes from your parents. And these genes are made out of DNA. And so a lot of people use those terms kind of interchangeably. It's our DNA or our genes, but it's basically like the DNA is just kind of the structure that makes up the gene. And most of the time when we think about our genes, people think about the genes that give us our outward traits, right? Like, what color hair am I going to have? Is it going to be straight or curly? Am I going to have freckles? You know, all of these things are coded for by our genes. And we get a copy of each gene from our mom and a copy of each gene from our dad. And that's why we look kind of like our mom's side of the family and kind of like our dad's side of the family, because these genes are passed from generation to generation by both of our parents. And so what we know now is that some of these genes that are passed to us from our parents are actually supposed to be protecting our bodies from developing cancer. And so if one of those genes is not working the way it's supposed to, then I'm going to have a higher risk to develop cancer because my body doesn't have the appropriate protection. So a mutation is a change in a gene, a change from what is considered normal. I don't mean it changes from point A to point B. I mean, like if I'm supposed to, I want to spell the word, cat, and instead of a C, I put a Z in there. Well, now that word makes no sense. So that change from the C to the Z is a mutation from what my word was supposed to be. So what happens sometimes is a gene carries a mutation that prevents it from functioning the way it's supposed to function. And that mutation, if it's in a gene that's supposed to protect me from cancer, then I'm going to have a higher chance to develop cancer because I don't have the sufficient protection. And because those mutations are found within the gene, those mutations can be passed from generation to generation. So circling back to what I was trying to get at before, only about 15 to 20% of ovarian cancers are due to mutations that we're born with in one of these genes that's supposed to be protecting us. And I say 15 to 20% are caused by, but really they're just pieces of the puzzle. And there's lots of pieces of the puzzle that cause people to develop cancer. And sometimes these types of hereditary genetic mutations are one of those puzzle pieces.
So thank you for the great explanation. So I do have a question, because when you were talking about these are the genes that we are born with, right? So we are born with a particular mutation, and sometimes there are defects, as you mentioned. Now, typically speaking, we are really not testing anyone genetically before a particular age, right? So even though we are born with those genes, we are kind of staying hidden, or I don't know, latent with that gene for many years before it actually comes to light. So especially for high-risk families, right? I mean, if you know that there's a predisposition to breast or ovarian or any other hereditary kind of cancer, what is the cutoff of the age when you actually take action? And if you are born with that gene, why wouldn't we do that testing even as a baby to kind of work with that knowledge?
No, this is a question that a lot of people debate and talk about, just kind of from an ethics perspective. Most of these genes that can impact our risk to develop cancer, they don't cause children to develop cancer. Most of these genes are what we would consider adult onset, meaning they're not going to cause a problem until we're adults. Now, what we generally do is look to see, is this a gene that could potentially cause a child a problem? And if it is, then we would test children. So there are some genes that we would test very young children for if it would impact their pediatric care. But in general, and not just from cancer, but in general genetic testing, if it's only going to impact an adult, then we like to wait until that person in front of us is an adult and can decide for themselves if they even want to know if they have that mutation. Some people don't want to know if they're in a high-risk group because the anxiety and the fear, it would just kind of paralyze them. And so some people say, I would rather not know. I would rather just if I develop a cancer, I'll deal with it then. Obviously, other people feel differently and think, well, if it could help me be more proactive, then I would want to know. And so we always do try to tailor, well, when do we first start seeing the cancers linked to this particular gene? And then we really try to encourage people to be tested and sufficiently early from that so that we can start screening before we would ever expect a cancer to actually start forming. So for example, the BRCA genes are two of the very most common genes linked to ovarian cancer and also breast cancer. But we don't typically see super, super young breast cancers, even with these BRCA mutations. And so we generally see those breast cancers starting in people in their 30s or older. And so we start screening for breast cancer at 25, unless there are breast cancers in the family at a younger age that would cause us to want to tweak that recommendation. We always look at the family history to try to tweak our recommendations for when screening should start. But there's just a lot of different things that come into play when we think about testing people for these genetic mutations. So we think about, do they want to know? At what age would it actually impact their medical care? At what age is there actual medical intervention or screening that we would want to implement? And all of those things go into the recommendation of at what age should people be tested for these. But there are some where we do test children if they would impact children.
That makes sense that obviously it's not an exact science and it depends on person to person, patient to patient as to what
gene to gene.
Exactly, gene to gene, exactly. So thank you for that clarification. So
but I will say, before we move on, just really quickly, in general, most genes we say once someone's an adult, once they turn 18 and can make a decision for themselves as to whether or not they would want to know, that's for the most part 18 is kind of the going age for when people could start being tested for these kinds of genetic mutations, unless there's a medical reason to test them younger.
Right, that makes sense. And like we all also know that because you carry the mutation does not mean that you are going to develop cancer. So that's where the anxiety and the fear comes in, that you may not even ever develop cancer, even though you carry the mutation. So then you have to balance your expectations and your, and your want to know more. So that it's a fine line. I understand that. So thank you for the clarification. So when it actually comes to high risk women, right, with family history of breast or ovarian cancer, for both the mutation carriers as well as the non-carriers like me, what would be your guidance for those high risk women, just in general, going forward in terms of surveillance or things to watch out for in general?
Yeah. So there's definitely kind of two different categories, like you mentioned. So if we're looking at a woman who has a mutation that we know is causing her to be high risk, then those recommendations are based upon which gene carries the mutation.
Right.
And so in regards to ovarian cancer, there are probably, I would say, 13 genes that the vast majority of us agree have an association with ovarian cancer. I mean, we're still learning about a lot of our genes. There's still a lot of data coming out, but I would say most people agree that there are about 13 genes that can impact our risk for ovarian cancer. And these genes that are protecting us from ovarian cancer are protecting us from other types of cancers as well. And so we would have to look and say, okay, well, which gene is your mutation in? And what other cancers have we seen in families who have carried mutations in that gene? And how high do we think the risk would be that you could develop one of those cancers? Right. And then what options do we have to address those specific risks that are dependent upon that gene? So we have lots of guidelines that we follow that help us make these kinds of recommendations based on each gene. The other alternative, like you, where there's a family history and we don't have an underlying genetic mutation, Then we make all of our recommendations based on the family history in front of us. It's very similar to, heart disease. If you've got a lot of heart disease in your family, then you know that you need to be more self-aware about your own heart,
Sure.
right?
Yeah.
So we really spend a lot of time making sure we have a good idea of all of the cancers that have occurred in a family and the ages that those cancers have been diagnosed, so that we can make a personalized screening plan based on the family history in front of us. And one of the rules of thumb that we use is that you should start your screening 10 years younger than the age of the person in front of you that was diagnosed. So if we use breast cancer as an example, because we know there's not great screening for ovarian cancer, right? So there's not a good way to say this is what we would do, but for breast cancer there is, because we have mammograms.
Correct.
So let's say a woman's mother had breast cancer at 35. Well, then we would normally say, well, let's start her mammograms, younger than that. So we would catch the cancer at an earlier stage. But really, we don't like to do mammograms before someone turns 30. So what we would really do we would do breast MRIs from 25 to 30. And then we could start mammograms at 30. So we can take a different example. Let's say my mom had breast cancer at 45. Well, then I would start my mammograms at 35. It's an easier situation at that point. Or if we can take the same thing for colon cancer. If my dad had colon cancer at 40, then I should start my colonoscopies at 30. So we really use the cancers in the family and the ages to determine a personalized screening plan. Breast cancer is a little bit has kind of an advantage over some of the other cancers in that there are computerized risk assessment models that can take into account a person's family history and a woman's own personal risk factors for breast cancer. So we all have different factors that can make our risk for breast cancer higher or lower than another woman's risk. And so these computer models can take into account all of those factors and the family history and actually generate a woman's risk to develop breast cancer. And so we can look at that and say, well, here's the average woman's risk to get breast cancer. And here's your risk based on all these factors. And here's what you should do about it. Maybe you should have a mammogram and an MRI every single year because your risk is high enough. Or maybe you should consider taking some medication that can lower your risk for breast cancer. So we run that risk model for many, many women if there's a family history of breast cancer to help us make a plan, a more proactive plan for her breast health. But for other cancer types, it's more just trying to make a personalized plan regarding when they should start their screening and what screening options are available based on what we've seen in their family.
Okay.
I hope that answered your question.
No, it does. Thank you so much. So we know that, all women with ovarian cancer, like 100% of women with ovarian cancer should undergo genetic testing. But from all the reports that I've read, it seems like we are still nationwide and worldwide at 35% or less, which is truly a shame that, we are missing out on so much for not just these women, but also their family members that could be impacted. So in your opinion, I know that there is no set guidelines for this, but just because you're so passionate about this cause, I just wanted to know that in your opinion, what would you do to improve the testing rates, especially in the minorities and the underserved communities?
Yeah, I wish I had an answer to that to help fix this problem. It's such a struggle to reach certain groups of people. Those are the same groups of people that don't tend to even come for their annual physical exams to even be kind of educated that they might benefit from talking to a genetic counselor about their family history. So I think that we have to expand outward more to the community and try to educate people through the community to even get them in to see their doctors, much less in to see a genetic counselor. And so, I think that there are a lot of wonderful community support groups like Overcome. There are lots of great ones for breast cancer and even for specific mutations. Force is another great one. And then there are lots of other great organizations that, are more local, not as international as you guys and as Force. And I really think that education through those kinds of community organizations to reach women in our own communities, to try to educate them about the importance of exploring this if they have a family history. That's my 2 cents for what it's worth. Is we've got to start before they even get into the doctor, because a lot of times they're not making it to those appointments, or if they see they come and have a mammogram and the radiology says, oh, you have a family history of breast cancer or ovarian cancer, you should have genetic counseling. They don't know what that is, so they don't follow through and make the appointment or come to the appointment. So it's all, to me, comes down, the bottom line is always education. And I just think education within the community is going to have the largest impact at this point.
And Cathy, you and I have talked about this. You know that through our Overcare program, we talk to our patients all the time. And, not always is the onus on the patient, because sometimes the providers don't talk about genetic testing, which is surprising, but it happens. So for ovarian cancer patients that we reach out to and speak to via our Overcare program, I cannot tell you, and we have, like I said, we have talked about this before, there are so many that tell us that no one talked to us about genetic testing even. And, in this particular segment, I would also argue that these patients rely very heavily on their doctors and their care team to kind of follow their instructions and do what they're asked to do, versus, ask too many questions or advocate for themselves. That's not everyone. So I feel like it's also on the healthcare spectrum, healthcare team, that they need to be more, what's the word I'm looking for, more proactive in talking to their patients about genetic testing. Because to me, that is a big miss, that, patients like these don't even know that they are supposed to do genetic testing, because they're not going to go to our websites or any other form of information to figure out that this is something they need to be doing. It needs to be coming out from the provider's, side as well. So I think there's a little bit of both in this. And like you said, all the advocacy organizations like Overcome and others will have to work together in kind of spreading the message and reaching this segment. So thank you for confirming that for us. So now, for patients or women that have already been diagnosed with ovarian cancer, right? We know that having the genetic testing helps with treatment options. So what are some of the new developments that you can talk to us about, or what are some of the things our overcomers need to be aware of when it comes to their own treatment with regards to genetic testing?
Yeah, so it's complicated because everybody's situation is a little bit different, right? The different types of ovarian cancer should have different types of treatment, the different staging, whether or not had a recurrence, all of those things play a role in what your doctor is going to recommend. Sure. But I think what's really important is if you have a BRCA1 or a BRCA2 mutation, talk to your doctors about a specific type of treatment called a PARP inhibitor.
Right.
Now, there are certain, everybody doesn't need to go on a PARP inhibitor right away. Sometimes they wait until you're finished with all of your treatment and they give you a PARP inhibitor as maintenance to try to prevent the ovarian cancer from coming back. There are different situations where the doctors may recommend starting you on a PARP inhibitor. It's not always, in fact, I don't think it's typically a first line of treatment. So if you're just diagnosed with ovarian cancer and you have a BRCA1 mutation or a BRCA2 mutation, I don't think that you would normally be put on a PARP inhibitor right away. That would be a question for the oncologist. But I think it's a conversation you have to have with them. So what would my options be? When would it be appropriate for me to go on one of these PARP inhibitors? Because we know that people with BRCA mutations respond really well when they're given a PARP inhibitor. So it's incredibly important that they at least have that conversation, so they kind of have a management plan sort of in their head. Like, okay, I don't need it right now because I'm doing really well on the treatment I have right now. But if this treatment stops working, then maybe we could try the PARP inhibitor. So I really shy away from giving advice really regarding, specific treatments. But I think it's super important that BRCA carriers know that PARP inhibitors are a wonderful line of therapy for them at some point. And then we haven't really talked about this yet. Everybody always talks about the BRCA genes being so important with ovarian cancer, but there's a syndrome called Lynch syndrome that is caused by mutations in a handful of other genes, which also are associated with an increased risk for ovarian cancer. And we know that people who have ovarian cancers associated with some of those genes, the genes that cause Lynch syndrome, respond really well to immunotherapy. And so for people who have Lynch syndrome, I always encourage them to talk to their doctors about, well, what options are available to them in regards to immunotherapy and what would be the timeline for something like that. So I think right now, those are realistically the main two treatment options that can be impacted by our germline genetic mutations. But we're still really learning about this area. It's a big growing field to see. We believe that there are likely other mutations that will also respond really well to PARP inhibitors. So I think that's going to be the next kind of area of growth, is it's not just going to be the BRCA1 and 2 carriers that respond really well, but I think we'll learn that there are probably other people who have mutations in other genes, for example, a gene called PALB2 that will likely also respond really well to PARP inhibitors.
Wonderful. Thank you, Cathy. So speaking of genetic testing, there are quite a few options out there for all of us, right? That include the easy and convenient testing that you can do from the privacy of your home versus going to the doctor's office, etc. So I know that there are benefits and challenges to both, and it's not always easy to determine which one is the best for you. And I'll tell you from my own personal experience that time is of essence, and time is so critical for all of us that sometimes just the thought of going to the doctor's office and being there for 5 hours or 6 hours to get the genetic testing done is enough for you to say, okay, I'll go next time. And this way, 10 years passes, which happened in my case. I waited 9 years before I got my genetic testing because time always came in the way for one reason or the other. So for people like us, the home testing sounds wonderful. You're like, you can just do it and get it done and ship it out, and that'd be it. So, but talk to us about the challenges of that. Talk to us about what would you recommend to our overcomers, or even family members of our overcomers that are considering genetic testing, to take which route and why?
Yeah. So first of all, it's always best to test the person who has cancer first. So I would always say it's, the overcomers themselves that should seek out genetic testing before their family members should. Because if I have ovarian cancer and I have genetic testing and it's normal, then that means my ovarian cancer wasn't caused by one of these inherited mutations, and therefore my family doesn't need to run out and get the testing done. Of course, the flip side is if my genetic test came back positive for a mutation, then we would know that I did have one of those mutations that could have been passed on to my children, and then they could go and get testing for the same mutation that was found in me. So we always really try to guide families to test the most informative person first, because it really will then inform the rest of the family. And so I think we always want to try our hardest to get the person who actually has cancer tested first. And I know that these direct-to-consumer at-home tests are so easy and so convenient for all of those reasons that you described. Nobody wants to have to go to a doctor's appointment here in Houston. Nobody wants to fight the medical center, all that traffic, So I will say, since COVID, we've had some good changes in medical care in that a lot of us genetic counselors are now doing telemedicine visits and video visits, and the labs that we work with will ship kits to a patient's home. And so I can talk to a patient and order their test through the labs we use, and they get the convenience of the test that I want being sent to their house.
Right.
So I do think, again, ideally, talk to your doctor, see if they work with a genetic counselor that can talk to you and coordinate that. We know we don't live in a perfect world, and many, many people don't have access to a genetic counselor, or like you said before, their doctors aren't even talking to them about this. And so there are some direct to consumer options where you can just go online and order yourself up a test. But I really am cautious and hesitant because all genetic tests are by no means created equal. The tests themselves are not equal in what they can detect. The interpretation of the results is not equal in the people who are determining whether or not that's really a mutation. The privacy protections are not equal. If you are being tested in a lab that's not bound by HIPAA, which HIPAA is the law that, protects all of your medical record information, some of these labs are not bound by those same privacy laws and can actually share this kind of data. And so I really tend to recommend against most at-home tests because you never really know what you're getting and you never really know how your information is being protected. One just simple example, I think most people have heard of 23andMe, and they say that they test for BRCA mutations, but if you read the fine print, they're only testing for 3 mutations in the BRCA genes that are very common in the Ashkenazi Jewish population. So if you're Ashkenazi Jewish, it's a better test for you because it's going to look at the 3 mutations that you're most likely to have. But there are actually thousands of mutations in the BRCA1 and BRCA2 genes. And that particular test isn't going to tell you if you have any of those. It's just going to tell you if you have one of the 3. But I think it's misleading. People think, oh, I'm having BRCA testing. And they don't realize how limited it is. And it's looking for 3 of the thousands of mutations that could be there. And so I would really only do a direct-to-consumer or take-home test that was recommended by a genetic counselor or a doctor. The National Society of Genetic Counselors has a website. It's just nsgc.org. And on there, they have a Find a Genetic Counselor tool. You can click on that, and you can put in your zip code, and you can choose what type of genetic counselor you're looking for. So you can choose cancer, and it will generate a list of genetic counselors in your area. And so if your doctor is not able to order genetic testing for you, or you simply have questions and you'd like to talk to a genetic counselor, I would say to go to that website and find a genetic counselor that you can call. I don't think it would be difficult at all to find somebody that you could just have a telemedicine visit with, that you could circumvent having to physically go into their clinic. It's just so common now that I think you could more than likely find someone near your area that you could have a phone call with, and let them guide you as to what would be best based on your own personal and family history, and let them order the test to be sent to your home.
Wonderful. And thank you so much for that clarification, because, I feel that it's important for all of us to understand clearly what are the challenges, even though the benefits seem very good, but what are the actual challenges of at-home tests? I think you walked us through that very nicely and beautifully. So thank you. Thank you for that. And now, we all know about Angelina Jolie and her decision a few years ago that she did her preventative surgery, right? So I was just curious because I read some other articles thereafter, which talked about this possibly more risk than benefit in elective surgery such as that one. So if there is no genetic mutation. So could you reflect on that for all women with family history with or without mutation?
Yeah, so again, it's more clear cut and easy when there's a mutation that would alert us that a woman has a higher risk for another breast cancer or ovarian cancer. Well, then we know that the benefit of removing the breast or the benefit of removing the ovaries would outweigh the risks of surgical complications because they would be getting the benefit of cancer prevention.
Mm-hmm.
I hope that makes sense. If we know you have
Yes.
a mutation, we know you have an increased risk, then we know you're going to get a risk benefit from, or a prevention benefit from removing those organs. The other side, again, is more tricky when there's a family history and there's not a known mutation, or if somebody themselves just has breast cancer and they want both breasts removed, but there's not a mutation telling us that they have a higher risk for a second breast cancer.
Right.
There are lots of studies out there today that actually prove for most women with breast cancer, the vast majority of women with breast cancer don't actually get any sort of medical benefit from removing both breasts. So we always try to guide women to do the most minimal surgery possible because it reduces the surgical risks and the surgical
Exactly.
complications.
Mm-hmm.
And so
Mm-hmm.
if you're not really getting a benefit, why put your body through that? I think too, people don't quite grasp the enormity of the recovery from a bilateral mastectomy. It almost seems commonplace these days, maybe just in the circles we live in. There's so many women who've had, bilateral mastectomies, but we don't realize how much of an impact that surgery has on our muscles, our range of
Mm-hmm.
motion, not to mention just our body self-image, psychological effects of having such a major surgery. Reconstruction is not easy. It's not
Right.
usually a one and done kind of procedure. It usually takes multiple procedures. I mean, there's lots of different types of breast reconstruction, and really that's a very personal decision too, based on your body type and what would be best for you. But the vast majority of the time, it's a lengthy process to be
Mm-hmm.
finished with the actual mastectomy and the reconstruction. And so I just always tell women to really have open conversations with their doctors about that, because most of the time when women want a bilateral mastectomy, they're wanting that out of fear and they don't quite understand that they're not actually going to receive a benefit from it. Now we have to flip the coin though and talk about ovarian cancer, because that's a very different thing as well. When people like you have a family history of ovarian cancer and there's not a mutation that says, well, your risk to develop ovarian cancer is high enough that you should remove your
Right.
ovaries,
Mm-hmm.
we still have to look at that family history and say, well, gosh, your mom still had ovarian cancer. And unfortunately, we know there's not a great way to screen for
Yeah.
ovarian cancer. I mean, there are things we can do, and there are things we're trying to learn to make better screening options available. But right now, we have transvaginal ultrasounds and we have the CA-125 blood test. And neither of those options is actually very good at
Exactly.
detecting
Mm-hmm.
ovarian cancer at early stages when they're easy to
Exactly.
detect. That's the goal. And so we do have a lot of women who say, you know what? I'm finished having kids. I'm already going through menopause. My body's not really generating those hormones anymore. Let's just go ahead and take those ovaries out as a preventative measure. And we certainly will support our patients who have a family history of ovarian cancer and don't have a mutation and want to remove their ovaries. Those surgeries can be done laparoscopically, which makes it a much easier recovery. Now, if they're going to take the uterus, that's a bigger surgery and a different kind of recovery. But if somebody's just going to remove the ovaries and that we want the fallopian tubes to come out too, that can be done with minimal recovery time. And if we're not receiving a benefit from those ovaries anymore, meaning they've already stopped releasing those, hormones, then there becomes a bigger benefit of why let them sit and develop ovarian cancer. Let's remove them if we're worried that this woman may have a higher risk. So I think that's a very personal decision and a conversation to have with a gynecologist. But I think one of the distinct factors is with breast cancer, we have really good screening tools with mammograms and MRIs, so we can watch a woman's breast tissue really closely. So if a cancer did form, we would hope to catch it at an early stage when it would be easy to cure. And we just can't do that about the ovaries. We don't feel confident that we have a great way to catch ovarian cancer at an easy stage, at an early stage when it would be easy to cure. So that's a big difference in surgical prevention versus screening.
Thank you. And you may have just planted a seed in my head for the future. I don't know, because it just seemed like it's an option that I should consider. I mean, a few years of time, whether this is not, because obviously I'm done childbearing and, my hormones are still working, but when they do, when I cross the bridge, then maybe this is something that I need to consider. So thank you so much for walking us through that. So generally speaking, though, when we are talking about these kinds of mutations, we are never talking about the father's side of the family, right? And which yet is so important, but it's often so overlooked, especially when we talk about women's cancers, right? So talk to us about that a little bit. Tell us about why we should not overlook the importance of inheriting mutation from dad, and how can this message be amplified, and what are we looking for if there's a mutation on that side of the family, and how can we be all more aware?
Yeah, absolutely, Runzi. Thank you for bringing this up. It's so important, this misconception that these mutations that impact female cancers are only important, from our mom's side. Yeah. That's not true at all. I can inherit a mutation that can give me an increased risk to develop ovarian cancer from my dad. We get a copy of each of these cancer genes from our mom and from our dad. So if there's a mutation on my dad's side of the family, he can pass it on to, just like my mom could pass one on. So it does not matter if you get it from your mom or your dad. You could easily get one from either side. It's just we don't usually see some of these cancers manifesting in men. They don't have ovaries, so we're not going to see a dad with ovarian cancer. They have very small amounts of breast tissue, so it's rare to see men with breast cancer. But if we do see a man with breast cancer, that is something that causes us to start to be more concerned that there could be something genetic. Because we think, well, why did this man develop breast cancer? Could it be because one of his genes that was supposed to be protecting him was not working the way it was supposed to? So that's a big red flag. A lot of these genes linked to ovarian cancers and breast cancers can also increase the risk for men to get prostate cancer. Correct. So we can see patterns of prostate cancer. So let's say your dad had prostate cancer and his mother had breast cancer. That might be a concerning enough history to look into further. It really depends on the characteristics of his prostate cancer and her age at her breast cancer diagnosis. But I think once you start seeing a pattern of some of these cancers, it's worth exploring. Many of these
where does pancreatic fall in this spectrum?
Great minds, Runzi. That was going to be my exact next statement, is many of these genes can also impact the risk for pancreatic cancer, and that's for men or women. So again, if you see, really, when I look at a family history, if there's anyone with ovarian cancer, I recommend they do genetic testing. Yeah. Anyone with pancreatic cancer, genetic testing. Breast cancer at 45 or under,
Mhm.
have genetic testing. So there are certain features, certain cancers and certain ages that just automatically warrant genetic testing. But many times it's more the pattern that we're looking at. There's a handful of people with breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, even melanoma can be associated with the
Oh.
BRCA genes. For
Mhm.
those Lynch syndrome genes, there's a high risk of colon cancer. So we may see dad had colon cancer. Those same Lynch genes impact the risk for women to get endometrial cancer. So we may see paternal aunts with endometrial or uterine cancer, and men on our dad's side, with colon cancer. So that pattern of colon and endometrial cancer could trigger genetic testing. But we really look at both mom and dad's side of the family because they're both equally important. It's just sometimes harder to pull out the clues from dad's side
Right.
because we don't often see the female cancers.
That makes sense. Thank you so very much. So we talked a little bit about the barriers to genetic testing, right? So I just had a curious question for you in terms of certain states are able to provide genetic counseling without licenses and others are not permitted to do so. So why is there an uneven distribution in expectations, and what should our overcomers know and do about this?
Yeah, so it really kind of boils down to there really aren't a lot of genetic counselors out there practicing. There's less than 6,000 of us in the entire United States, and less
Wow.
than half of us, see people for cancer indications. So
Yet
this
there are
number,
millions of cancer survivors in the country. Wow.
right. So the number one problem is there's not a lot of genetic counselors. And so
Mhm.
for someone, so I guess again, to kind of back up, genetic counselors are trained professionals who have a specialty master's degree specifically in genetic counseling.
Mhm.
And when you graduate from a genetic counseling program, you are then, you sit for a certification board exam from the American Board of Genetic Counselors. And so you become a certified genetic counselor.
Mhm.
So there are less than 6,000 certified genetic counselors in the United States. And so one of the most important things is if you're meeting with a genetic counselor, you want to make sure they're a certified genetic counselor, or maybe they're a new graduate who hasn't taken her board exam yet, but she's board eligible.
Right.
Because there are so few of us, you have other individuals who will sometimes provide genetic counseling, but they're not genetic counselors.
Mm.
And there are pros and cons to this. There are nurses who are very well trained in genetics and who can absolutely guide someone through all of this and coordinate the appropriate test and counsel them as to what the results mean for them and their family. I mean, there are people who are not genetic counselors who have been doing this for many years because they didn't have a genetic counselor in their area to do it. And so that's part of the trickiness is if a state decides to license genetic counselors, then only certified genetic counselors
Yeah.
are going to be able to apply for those licenses, and only licensed professionals are then going to be able to provide genetic counseling services. All of those nurses who have maybe been doing this for years very well will no longer be able to do it.
Right.
And
Right.
I believe that in the state of Texas, that is the biggest glitch right now. We're one of the few states that aren't licensed, but I really think that that's part of the bigger issue is there's not enough of us to go around, and the fear is we may limit access by licensing us. The flip side to that is you can't guarantee quality of who you're talking to. If anybody that wants to can tell you they can give you genetic counseling, how do you know what kind of training that person has really had?
Right.
How can you trust that you're actually being advised appropriately? So we really worry about the harm that could be done without licensure because we can't guarantee that everyone that's providing genetic counseling is providing accurate, reliable, trustworthy counseling.
And
So
in
the
situations like,
frustration.
yeah, and in situations like these where it's cancer and I mean, it's not just your not just one person's life, it could be a multiple of generations, you know, impacted by it. Like you said, we need to have the most qualified people that actually do the genetic counseling. But then there's also this added layer of restriction that even if you are certified in one state, you are not able to counsel
Right.
in other states. So it's just very limiting. And it's
It
not,
is.
to me, it just almost seems like it is not in the benefit of the patient, you know?
Yeah, I mean, it definitely adds an added struggle. Physicians are licensed state by state, but there's enough of them to go around. So there's
Right,
not that
right.
added complication of, the lack of access, because we just, there's just so few of us.
Yeah.
And like you're right, licensure is then, like, I cannot counsel a patient in another state that requires licensure because I don't have licensure in that state.
Right.
So it definitely limits how we can counsel people who are not in our own state.
Yeah, that's what I was thinking, because, you know, we are already at a low with, you know, genetic counseling and testing, but with all these added layers of complexities, then we are even, like, you know, we are missing out even more, is what I'm trying to say, with all these layers that you could have now counseled patients in other states, but yet you cannot because of the guidelines. So, you know,
Agreed.
these are things that we need to talk about and possibly bring to attention and change going, and you know, demand a change going forward. Because to me, like I said, it does not seem like it is in the interest of the patient, because the patient would like nothing but getting genetic counseling from someone like you, who is an expert in this field and knows what you're talking about, you know. So it's so important that we raise our voice to that. So thank you for mentioning and you know, sharing your thoughts on this. So I'm going to talk about, you know, another debatable issue, which is the insurance, right? I mean,
Yeah.
so so, you know, we know that it has eased over the years when it comes to genetic testing. But again, from talking to several of our overcomers who are in the community hospitals in the rural areas, this knowledge has not it's not commonplace, in the sense that there's still this whole question of, oh, okay, I don't know whether my insurance is going to cover it, what's going to happen. And there's a lot of, like, you know, that is a barrier, even though it is not a barrier, but the lack of information and awareness can become a barrier. So from your perspective, tell us where we stand today when it comes to insurance and genetic testing. What are some of the resources, options that our overcomers may have, and any other things that you would like to share?
Yeah, you're absolutely right. And that I think there's a lot of misinformation out there. Back in the day, when we were only testing for BRCA1 and BRCA2 mutations, just that testing for those two genes was like $4,000. So it was
Right.
incredibly expensive, and it was more difficult to get insurance to cover that. And so I think that lingering idea that genetic testing is very expensive and the insurance won't cover it, we haven't been able to get rid of that long-standing belief. But it really is not the truth anymore. I mean, I know every insurance plan and policy is different. I am not aware of any insurance plan that would not cover genetic testing for a woman with ovarian cancer. We have national guidelines that recommend
That's
who
right.
should have
Mhm.
genetic testing. And those guidelines recommend that all women with ovarian cancer have genetic testing. And most insurance policies follow those guidelines. And I have to say most, because some don't. But again, I'm not aware of any insurance plans that genetic testing would not be a covered benefit for a woman with ovarian cancer, or for a woman who already or a man for that matter, who has a known mutation in their family.
Right.
But with that said, it doesn't mean that the test would be covered completely. It doesn't mean it would be zero out-of-pocket cost for that patient. Certain plans, we all know, have co-pays, or maybe I haven't hit my deductible and I want to have this test, but the cost of the test has to go towards my deductible. And so there are individual factors that could cause people to pay a different amount for their genetic testing because their plans are different. So you always have to go back to your plan, to find that out. But I will tell you that most people pay under $100 when they meet the criteria, which again, I've never run into a plan where an ovarian cancer patient wouldn't meet criteria. Many people don't pay anything at all because they've already been through, cancer diagnosis, cancer treatment. They've already hit their deductible. So when it comes time to do the genetic testing, many of the times they don't have any out-of-pocket cost at all. Many of the labs also have fantastic patient assistance programs. So for people who are uninsured, if their income is below a certain level, the labs will test them completely free of charge. Many of the labs also have a sliding scale for financial assistance. So even if you have insurance, if my out-of-pocket cost is going to be large, then I can apply for financial assistance, which might help shrink my out-of-pocket cost. So I really think the best resource is to go to the lab that's going to do your test and ask them what types of financial assistance do they have. They're very generous. These labs are incredibly generous. Their programs are very easy to apply for. And I mean, really, finance should not be a barrier anymore because of how well insurance covers it and all of these financial programs for those that are not insured. So both groups should be really fairly well covered now.
Absolutely. And I also feel that, this is the kind of information that our patient population, especially in the community setting and the smaller hospitals in the rural areas, they need to receive this kind of information, that there are options available outside, that you could even get your genetic testing and counseling done for free. I mean, with some of these labs. So I feel like there's a knowledge gap between what is being offered and what is readily available to all of us, or all of our overcomers. There's a lot of it's lopsided, for the lack of a better word, I think. So we need to just keep amplifying this message that if you do want to get your genetic testing and want to get counseled, there are options. It's just that you have to just kind of seek out some more information, talk to your healthcare providers, talk to your nurses, talk to your team. If you do not have a genetic counselor in your institution, just have them give you information about where to go and how to seek genetic testing, which is most cost effective for you. So thank you for walking us through that as well. So Cathy, fantastic conversation. As always, you have walked us through so much when it comes to genetic counseling, genetic testing. We've talked about some hot topics also, which is exactly what we like to do on our Connect Over Coffee series, candid, coffee chat, right? So thank you for being, forthright in your responses as well. So just in closing, I just wanted to ask you, because you're so passionate about our overcomers, and your commitment to our cause is very, very appreciated. So what message of overcoming would you share with all our audience and the listeners, not just nationally, but globally?
Yeah, the most important advice I can give is to get that germline genetic testing if you haven't already done so. It's just so incredibly important, in that it could impact treatment and your overall, treatment plan. So it's so important. And if I could throw in one more very, very important piece of advice, is if you do get genetic testing that finds one of these mutations, please, 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 please share this with as many of your family members as you possibly can. I mean, it could be life-saving information for women and the men in your family. And I just think that piece sometimes get lost too. People feel awkward or uncomfortable talking about this with their families, but really our goal in genetics is to find people who have these mutations before they get cancer, so that we can give them things to be more proactive with their screening and prevention to prevent them from ever developing a cancer. And we know that we can't prevent all cancer, so sometimes it's just changing screening, so that if a cancer does form, we would catch it at an early stage when it would be easier to cure. But I think that's a second really important message, is you can't just stop with getting yourself tested. If it's positive, share that information with your loved ones to try to prevent them from having to go through what you're going through. I have an analogy I'd like to share. It's kind of a cheesy analogy, but I really think it helps. So I always think of it like if I had a room full of furniture and I told you, and I turned off the lights and I told you to get from one corner of the room to the other, you would probably bump into something, right?
Yeah.
But if I gave you a flashlight, then you could use your flashlight to see what you were at risk to bump into. And so hopefully then you wouldn't bump because you would have seen it coming. Or if you did bump, it'd be a softer bump because you saw it coming. So to me, genetic testing is turning on that flashlight to see, what am I at risk to bump into? I mean, the truth is we're all at risk to bump into stuff. We just don't know it because we're just running around in the dark. We don't know it until we make that hit. But if I had a genetic mutation that I knew about, that's like turning on my flashlight. So now I know what I'm at risk to bump into, and I can take advantage of things to try to prevent myself from bumping. And to me, that's what this is all about. If I already have cancer, I don't want to bump into anything else. Or if I don't have cancer, I don't want to ever bump. So I encourage people to think about that. Some people tell me they don't want to turn on their flashlight, that it's too scary. They'd rather run around in the dark. And so it's a very personal decision, right? I mean, and sometimes our loved ones don't make the decision we want them to make, but at least inform them and let them make their own decision. Make them aware if this is in the family so that they can get appropriate guidance and care.
Thank you, Cathy. And I can tell you this very confidently that anyone who's watching this will not forget this flashlight conversation. So thank you so very much for making it. No, this was very powerful, by the way. This comparison, this storytelling that you did, it made it so much clearer to all of us, that why is this important? So I will never forget the flashlight conversation. So thank you so very much, Cathy. This was fantastic. And I know that, you have always been such a great supporter of Overcome. We appreciate you very much and for your time and your knowledge and for you, always sharing your best with all our overcomers. So thank you very much for coming to this episode of Connect Over Coffee. And overcomers, hope this was beneficial for you. I think this was one of our best conversations we have had on genetic counseling and testing. So simple yet so powerful. So I would very much encourage all of you and request all of you to share this video far and wide with anyone who may benefit from this great insights and information Cathy just shared with us today. We will be back with the next episode of Connect Over Coffee very soon. Until then, you keep talking about ovarian cancer and keep overcoming. Thank you and bye.